Hey everyone, I'm Dr. Matt Najad, and today I'm excited to talk to you about the Nimbus toothbrush. I'll be explaining what makes the Nimbus so unique and effective. So first of all, what is the Nimbus toothbrush? Well, it's a manual toothbrush that was invented by a periodontist with the goal of gentle but effective in mind. The Nimbus microfine toothbrush uses a unique design with 2 levels of tapered extra soft bristles. Longer tapered bristles gently and effectively reach into those critical areas between the teeth and along the gum lines, clearing away plaque and debris, accompanied by shorter supportive bristles that help brush away the remaining particles, ensuring a thorough, gentle cleaning. As you can see here, the bristles gently move between the teeth and under the gum line, sweeping away plaque and massaging the gums. By using a true extra soft bristle in the original Nimbus 2-level tapered design, Nimbus has greatly reduced the risk of recession and other trauma to the gums and tooth enamel. Additionally, the 2-level bristled configuration allows for a gentle, deeper cleaning around the gums and around restorations like crown and implants where plaque accumulates. For this reason, Nimbus has been highly recommended by periodontists, oral surgeons, implant specialists, and dentists alike. Nimbus offers 3 styles of their extra soft, microfine toothbrushes. The Nimbus regular head offers the traditional full-size brush head with microfine extra soft bristles, and this is perfect for most people, and that's what I use. The Nimbus compact head features a slightly slimmer brush head with microfine extra soft bristles and a standard adult length handle. So this is great for those with smaller mouths, kids and teens, or those looking for a bit more brushing control. And then there is the Nimby, which is the child-sized toothbrush. It has a shorter handle for easier gripping and a smaller brush head with extra soft bristles. The brush is for younger kids up to around 10 or 11 years old, and the Nimby has also been used by adults looking for a firmer grip with the handle. But what makes Nimbus stand apart from the rest is Nimbus uses high-quality materials and has strategic placements of its bristles, ensuring a truly effective and extra soft experience, rivaled by none. I've been using the Nimbus toothbrush for the past 10 years. It's excellent for gentle and effective plaque removal. It reaches into critical areas between teeth and the gums. Due to Nimbus's commitment to quality, the Nimbus toothbrush is the choice for many dental schools, hygiene programs, and hospitals for its superior quality and effectiveness. Thank you for joining me, and for further information, please contact the Nimbus representative.
Charles Spitz, DDS, was born and raised in Cleveland, Ohio. He went to undergrad at The Ohio State University. He always, from his youth, wanted to work with children and decided to become a pediatric dentist. He attended dental school at Case Western Reserve University. After dental school, he served in the U.S. Army from 1967 to 1969. He's a decorated Vietnam War veteran and was presented the Bronze Star Medal for his service. After returning home from Vietnam, he attended his residency in pediatric dentistry at Case Western Reserve University. Upon graduation from his pediatric residency, Dr. Spitz and his wife Beth moved out west to San Francisco. Dr. Spitz was hired as the director of the Pediatric Dentistry graduate program at Children's Hospital Medical Center in Oakland. He started his own practice in the Mission District of San Francisco in 1975 and has served Bay Area patients ever since. In 1985, Dr. Spitz opened the current office in San Mateo, where he has practiced for over 40 years. Tyler Davis, DMD, married the love of his life, Kimmy, and moved to the Bay Area in 2012. Kimmy is a native of the peninsula and grew up 5 minutes away from Dr. Davis's current office location. Dr. Davis and his wife have 4 children, Charlotte, TJ, Macy, and Ella, which keep them busy all year long. Dr. Davis and his 2 brothers are all pediatric dentists. It's safe to say dentistry runs in the enamel in his family. His brothers and father practice together in Tucson, Arizona. He's an avid dental literature reader and is proactive on staying up to date on all the newest materials and equipment in the dental field. Welcome, Dr. Spitz and Dr. Davis.
Appreciate that. First of all, the shout out to the vendors. Jonathan worked with Nimbus for a long time, I feel like now, and it's been great. Having vendors at our society actually gives us the opportunity to do things like this, so we appreciate all of that. I've started working with Jaeger not too long ago, 3 or 4 years ago, and it's been an unbelievable experience. Fortune, I haven't had the joy of working with you guys yet, but I talked to you guys tonight, and I'm excited about where that can go too. So, anyways, I think that's a good plug for all of you guys, and I appreciate what you guys do for us. So, anyways, Dr. Spitz, the man, the myth, the legend. I think that's what you guys all showed up to hit here and get tidbits and joy and everything. I've been able to do that for the last 14 years, which has been pretty fun.
We've enjoyed it.
Anyways, how do you get in a study club and get like sentimental like that? I don't know, but it's been a pleasure practicing with you. It's been awesome. Anyways, what we're going to talk about tonight is conservative pediatric dentistry. It's something that I didn't know anything about when I came out here to the Bay Area. It's something that Dr. Spitz started doing a while ago, and then we together have honed it into like what we enjoy doing, which is dealing with families and patients and being kind of on the forefront of what things that you can do differently than like what other people don't see. And that is kind of like the crux of what we do. It's an everyday kind of journey with families that come in with different wants and wishes. And, you know, do you do GA? Do you not? Do you do SDF? Do you do all of these different things? And there's so many different materials and modalities that we can use these days. And I think that's like the beauty of kind of where dentistry is going. Dentistry is one of the, probably in terms of like professions in the medical field, it has materials that are expounding daily. Like there's new things that come out daily that we as clinicians like kind of have to think about or want to use and don't want to use. 3D printing, like Jim was talking about earlier, or Sarah was talking about earlier. It's something that I like am near and dear to my heart because I think all of these things are on the forefront of what we're going to do in the future. So what we're going to talk about is conservative pediatric dental care, behavior management, techniques for parents and caregivers, like for home care with infants, toddlers, teens, and special healthcare needs, kids and adults. Like we see our oldest patient is Cha-Cha. How old is Cha-Cha?
She's
69?
in her fifth. Yeah,
We
see a lot of special needs patients every day, and God bless them and God bless the parents. They never matriculate out of our practice. I mean, that's our little give back, because after a while they be comfortable with us. And yeah, Cha-Cha is the oldest one. So we see lots of them in their 30s and 40s. And, you know, once special needs kids or adults get to know you, they're very comfortable with you. They want the same room. They want the same dental assistant. They want the same thing on the TV. So they never matriculate out. When I first started practicing, you know, patients would stay until they got out of high school. Now we have to throw them out after college.
Yeah.
Then it's so much fun. And it's so much fun. I'm blessed because I've practiced for 200 years now. So I see many, many second generation patients every day. And I just feel very blessed that they can come in, and it just makes life for us. So it just makes it so much easier for us. So to answer the question, yes, we see kids until they get out of college, if they want to stay. And the special needs kid never matriculate out of our practice. The parents have enough things to deal with, and that's our little give back that we can give to them.
And it's just, we like with that, like as kids get older, there's different concerns and things that we discuss and talk about with the parents and the families. We do soft and hard tissue laser treatments with, I use a water laser. I mean, there's a lot of different lasers that are out there, but I do think that like using a laser in terms of in dentistry, if you're not doing it, it's probably something that you will do in the next 5 to 10 years. And I do think that it is, I mean, there are limitations, don't get me wrong. Like with using a laser, you know, you first go into it and you're like, oh, this is going to be the best thing of all time. Everything's going to be, it's like one, you know, nail and we're going to hammer it and it's going to be great. And it doesn't work like that, but it is fantastic for hard and soft tissue. Soft tissue, I really I didn't think I was going to use it for that as much as I do now, and I do it a lot more than I thought I was going to. Technology, near and dear to my heart. My older brother started AlphaBite with one of his best friends, and then we also partnered with Xylo 3D printers, which Sprint Ray is like kind of the leader in all of this. Xylo is a 1-unit 3D printer that there's 3 in the United States right now. There's 5 more that are coming. I'm getting one of those, and I'm going to start printing a lot of different things. I think that printing is kind of where it's going in terms of appliances and things of that nature. You were talking about crowns, I think, earlier. So anyways, AlphaBite does a thing with Xylo where they print pediatric crowns that you can print in, 15 minutes and have a Rolodex of 20 different crown sizes, and they have 2,000 sizes for those crowns. So I mean, it's stuff like that is, it's just cool. And they're like stainless steel crowns. They're like a zirconia crown. They have the same wear resistance as a zirconia crown, although they've been out in the field for about 2 to 3 years. So like, what's the longevity on that? Pediatric dental crowns don't need to last forever. They fall out at some point, right? But I do think that's like the horizon of where it is all going. Trauma cases, I mean, we do trauma a lot. I think you probably all do a little bit of trauma. I had just put one case in here of rebonding a fragment of a tooth because I think it's interesting to see, and I think that as general dentist or specialist, I think it's a good modality of treatment, just in general. So anything that you want to add?
No, I just will say, when you get out of dental school, that's when you start learning. And I'm not being sarcastic, and I've been blessed with this young tall man because he's carried it forward. I'm learning from him. But I think the point is that you need to keep growing. If you stop growing, you die. You never stop learning. I don't care how old you are, whether it's in dentistry or what have you. I've been blessed with him because he's taken the materials and all these things, and I've learned a lot as I've gone forward. I think that's something that whether you're with somebody or you're alone or you have a partner, I think it's really important to continue to learn, because you just start when you get out of dental school. What we do now, and even Tyler just mentioned, it's so different now than when he got here 12, 15 years ago.
Completely different.
Totally different than when I got out of dental school. I mean, the materials, blah, 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 we don't need to say it. But the important thing is keep learning. Keep learning, because things change and they do get better. And it just makes life easier as you grow, as materials and modalities change. So I thank him for that.
Yeah, and it's true. And to be, I mean, not older and be able to like change and adapt to the times is a special thing. So our conservative approach, this is kind of like cookie cutter sheet of like what we kind of do. We look at, when a patient comes into the office, we look at what is the parental involvement with the child. Are they coming in with a nanny? Are they coming in with their mom and dad? Is it the firstborn? Is it the eighthborn? Like where are we in the pecking order? Like what are they looking for in terms of what it is that we can provide them? And from there we go down to the patient's behavior management. How are we going to manage this child? Is it a 2-year-old that's coming into the office? Is it a 12-year-old? Is it an 18-year-old? Are they going to laugh at my jokes about boogers? Are they going to think that my haircut joke is funny? It's stuff like that we're looking at. And we're looking at kind of how they're interacting with our staff, as well as with their parents, as well as with us as we walk into the room. Modalities of treatment, I kind of listed things that we do. We work with Elevate Oral Care and use their Just Right toothpaste, which I think is fantastic. It is 5,000 parts per million. It has 10% xylitol in it, which is a karyostatic. Like, using those two modalities back to back is an unbelievable thing. And I think that it really has, in the last, we've used it for probably 2.5 years or so. And it's been fantastic. People like it. They pick it up from our office. Like, that is one of the things I used to get so annoyed with, Dr. Spitz. I mean, everybody that come in 6 months later, they're like, I forgot to get it.
That's Prevident or any of the others that you get. So now we dispense it. And we do it in a nice way. I don't mean to interrupt you.
Yeah, no.
We have 3 different flavors. So the nurses will come out on a Q-tip, the different flavors. We do a taste test. So we break it down to something that's simple. So they're involved. they're making the choice. Oh, I like this one, or I don't like the bubble gum, or I like this one, or I don't like the mint. So they're involved, and it's very easy. We're not selling anything because this stuff really is good, and we see a big difference. But the compliance is good, and that's what you're alluding to.
Yeah.
When you say, oh yeah, we're going to call something in, a Prevident prescription, they never get it. So with this, the compliance is good. We give them a little card that says, how you brush, and you floss first and brush. Don't rinse when you go to bed. The compliance is great, and results are wonderful. Again, this lends into how our conservative approach is.
That's exactly right. And we call it 31 flavors. 3 flavors, you pick one.
Yeah.
31. Baskin Robbins, nobody.
That's
ice
it.
Cream fans.
That's
Come on, that's good. That was my joke. Anyways, but I do say that on a daily basis. I'm like, hey, this is like 31 flavors. They're like, whoa, you have 31 flavors. I'm like, well, not so much. We have 3, and you pick one. 30. Anyways, sealants on permanent molars. We don't do a lot of sealants on primary teeth, but we do a lot of sealants on permanent molars. I think that any time that you can prevent something, it's better off in the long run. I don't think that any parent will bat an eye about any of that. It's something that we're firm and willing to discuss with anybody, but we also are pretty like, this is what's best for your child in the long run of their life. And doing that is something that I think is a great thing. SDF, NSF, 2 different things, right? So silver diamide and then nano silver. Started using nano silver probably 6 or 7 months ago, right when it came out, and I love it. I think it's fantastic. I think the research shows that it's amazing. It doesn't stain. You're not using iodine like some of the other ones that you use that don't stain, but then you get the taste and everything else. NSF tastes good, looks good. Now it's kind of hard to get, so don't all go out and try to buy it now because I'm still trying to get it again. But SDF, unbelievable medicament. We've been using it for 6 or 7 years or so. I've been talking about it with my brother probably for 14 years. They used it in Maine a really long time ago. I used to see it in Boston when kids would come over from Japan. I mean, you went to dental school at NYU, right? And so like they come in black teeth and you're looking at it and you're like, what in God's name is happening? And then you open up their mouths and you check them and you're like, oh my gosh, it is so hard. Didn't look good. Don't get me wrong. It does not look good. But if we're doing SDF, we do it on primary teeth. We only do it on posterior molars. You don't see it on anterior teeth. We talked about this earlier today and we'll talk about it later today. And I don't know how much time I have, but we're going to talk a lot.
No, you're going to talk a lot.
Yeah, well, you'll talk too. The silver diamide, so anterior teeth, they exfoliate between 5 and 8 in terms of like the pediatric population that we're seeing. So if they have incipient lesions and even bigger lesions on anterior teeth, we're not doing a whole lot with those. We're actually just going to watch them exfoliate, and parents appreciate that in terms of our conservative approach because we're going to focus on the posterior teeth that are going to be there till they're 10 to 12 years old and then exfoliate at that time. But we're trying to space maintenance. Obviously, James, you want us to do that. We want to make sure that we keep all of that space so that they can get ortho and everything looks good when they're older. But SDF, huge. I love it. Fluoride varnish. We just switched to a ClinPro fluoride varnish from 3M. If you don't use a fluoride varnish, you should use a fluoride varnish. And you should use the ClinPro fluoride varnish. I don't get any money from ClinPro, or I don't get any money from 3M or Solvent, Solmentum, or whatever. But their new fluoride varnish, which is unflavored, not sticky, water-based, unbelievable 15-minute protocol that they don't eat or drink anything. And then after that, you can do whatever you want. Literally, what do we say when they leave in the office? You get to the car.
You get to the car, you get to school, something. You can have something.
I mean, they're checking out, they're doing all this stuff. They get out to the car. That's 15 minutes right there. So that fluoride varnish, we started using that about a year ago. Maybe a little less than a year ago, something like that. And it's been amazing. Anyways, we do oral hygiene checks, especially when kids are in ortho, or if they're with oral hygiene check is when we see them every 3 months and we do cleanings and then we do fluoride varnish afterward. But that we find works really well for like white spots and things of that nature, especially kids in ortho. GA, this is one of the things that, I mean, general anesthesia or having an anesthesiologist come into your office to do different things. I think with that, it's amazing to have all the modalities that you can do. So when I talk to a parent and I say, hey, listen, looks like a house is on fire. Okay, well, let's see what we want to treat. Is there anything that's bothering you? How do we go and stem this down the way? Do we want to put your child to sleep? Do you want to just be done with this and be done with everything that we need to do in their mouth? Or do you want to stepwise it and go the slow route? I tell you what, 99% of them say we want to go the slow route. We want to do SDF. We want to do the fluoride toothpaste. We want to do fluoride varnish. Let's do all of that. And then let's see. And you know what? I'm cool with that, because if in a year from now that modality doesn't work, guess who is involved in that decision? The parent.
Yeah,
they were involved in all of that decision making.
You just have to always give all the options to parents, and they make the ultimate decision. Like you said, we can take the conservative approach. 95% of the time, the conservative approach works wonderful and the teeth fall out. But if you give them the option, and then just make sure that it's documented. I mean, I would assume almost all of you have computers, use computers. You have a nurse in the room.
Do you?
No, you have one because I came with you. No, we switched when we came from the other office. But as long as it's documented and they're participating in the decision, number one, they're going to accept what you want to give them. And number two, because they participated, they're involved in it. And 99% of the time, it just goes down the road and the teeth are exfoliated. But it's documented. So we're real big on keeping parents involved from the day they walk in, like, how may I help you, not what the hell do you want. You start in the very beginning developing relationships. And then it gets to this where there's clarity and there's understandings. There's never misunderstandings. The other thing, we always have parents in the room all the time. I don't care if we're taking teeth out or whatever.
Totally.
Unless moms get so squeamish, oh, I can't look, I want to leave. That's fine. But we always invite them in for lots of reasons. One, if the kid's not so good, we want mom to see this kid's a shithead. But you want the parent there because you want the involvement.
You're going to have to edit some of this stuff, bro.
Yeah.
You can't just throw this on the website.
Yeah, I know.
Right?
I have a problem with language. My year in Vietnam changed me substantially. I had to be retrained by my mother when I came home before grad school. Anyways, having parents involved is so important on all levels, from the day they walk in until they leave. And you know what? Then everybody's happy. Everybody has clarity, and everybody's friends. Yeah. And that's really the bottom line.
It leads us to the next thing, like treatment options, or options for treatment. Just like the toothpaste, where kids like to choose their own toothpaste. Well, you know what? Parents like to choose what their kids are going to do too. And that leads to the discussion of like, well, A, we do nothing. B, we do something. C, we do everything. And you come into the meeting of the minds where like it usually lands around B or B1A, where it's like, okay, let's do SDF, let's do the fluoride toothpaste. You get some parents that are like, listen, I don't want anything done. Can we go that direction? It's like, yeah, I don't know how long that's going to work, but like, let's try it and see what goes on. So as long as you're communicating with them and to like Dr. Spitz is saying, and documenting everything that you're doing, I think that's like the benefit of being able to discuss all of those different things with them, and saying no, that you don't want treatment. It, like, I think a lot of us, like as clinicians, like when we first started doing this, and I was like, tell somebody, oh, you need a DO on L, and they'd say, I don't want to do that. And you're like, wow, they don't trust me. Well, it's not that they don't trust you. It's that they themselves can't get their head wrapped around how this is going to happen to their child and everything else. So I've gotten to a point where it's like, listen, these are your options, X, Y, and Z. Choose one, choose none of them, choose all of them, choose whatever you want. And it leads to great conversations. It leads to a closer bond with our families, the people that want to come send their families and friends to us. And I think that's one of the biggest parts of that too. Home care. What we do in the office is like 2% of what the kids are going to experience on the outside. You have to do home care, or else you take them, put them to sleep, put every crown on their tooth, and the next time they come back, everything's abscessed. It's not because of your work was bad. It's because they don't have the right tools and everything at home to do everything. And so our thing, and like, we started doing this, I don't know, like 10 years ago, talking to the parents about, I mean, we've always talked to them about home care, but we tell parents, lay them down in bed. I mean, I lay my 11-year-old down in bed with pillows behind her head and I brush her teeth 3 times a week. I floss her teeth laying down. I think that it's easier to do all of that with their head still. I think flossing teeth with the head flopping around in the back, it's harder to get back there. Harder for the child. Harder for the toothbrush to get back there because you're jamming it back in the vestibule. So we tell parents, hey, 2-year-old, lay him down in bed. I mean, there's the technique they all like to tell me about, that where, you know, the guy on Instagram puts the kid on the floor with their arms underneath the legs and they brush like with the head in between their legs. I'm like,
No.
all right, that sounds weird, but like do it if you want. But like laying them down on a bed or on a changing table when they're 2 to 4 years old, it's a great time to lay them down, brush their teeth, use a grain of rice size to fluoride toothpaste. They can swallow all of that totally fine. I think a lot of the things about fluoride, I mean, we could get into that too. I mean, there's a lot of things we can talk about. But I think fluoride, in the latest research too about hydroxyapatite, I don't know if all of you guys know that, but it does nothing. Does nothing. So please, I used to say hydroxyapatite was 1B. It is not even on the list anymore.
No, it doesn't.
It's not even on the list. So you go from fluoride to xylitol toothpaste, and then just after that, use water. Unless you want to rub your teeth with rocks. Like hydroxyapatite doesn't do much. Oh yeah, dude. Oh, sorry. We didn't say that in the beginning. But ask questions whenever you want to. Go ahead. Got none for you, actually. Yeah. Yeah, for the...
I know in general sugar alcohols generally cause like stomach upset and digestive issues. I don't know how it pertains specifically.
Well, so that's xylitol. I mean, for sure, like sugar alcohols, like what you're talking about.
Yes.
Like if you're gonna, if you listen, these, you eat a whole pack of these mints, you might have some gastro issues. Not gonna lie, but I like what we're talking about is a pea-sized amount of fluoride toothpaste with 10% xylitol in it. You're swallowing that twice a day per se. I mean, I use it on my 4 kids have used it for the last 2.5 years. And I mean, we're talking as early as like 1.5 to 2. And then my oldest one started using it when she was like 8.5 to 9. And I haven't seen any gastro issues with that. So, but that's anecdotal. Like I can't speak to like whether or not like there's something, I mean, prebiotics, probiotics, we do a lot of that in my house anyways. That's another thing. I'm the president of the San Mateo County Dental Society this year. And my big thing is like health and wellness for not only for our patients and everybody, but for us physically as dentists. Like I think that we as a profession need to do a better job taking care of ourselves. I want to be like you. I want to be like Fred over here. I mean, look at these 2 dudes. Like these guys have practiced for 50 plus years and have been doing it and doing it well for that long. That's freaking amazing. It really is. And that is, yeah, let's give you a round of applause again. Yeah, there you go. But I think that like, it's really important to like focus on ourselves too. I just started doing this for myself like 2 years ago. My kids were young, everything else, couldn't find time to go to the gym and do all of this stuff. And now I find the time for myself because I find if I don't, I'm not good at anything that I do. So anyways,
That's true.
That's a PSA.
When you talk about flossing and stuff like that, what we do in our office, because they lay down and the parents see us doing the flossing, and we say, you can do this on a bed. So
Yeah.
we're giving them a model to the point parents say, why are they so good for you? And I said, that's because it's us. But then I have some of them, they'll take a video with their little phone because we lay them down and we do it. And that's what Tyler just said. And they just emulate that at home. So then it's easy. You know, you did it for Dr. Davis. Why can't you do it for me? Here's the video. And then
I completely agree. And the other thing is we don't say you got to do this twice a day, every day. We're realists as well, right? If we can get our patients to do that 2 to 3 times a day, or sorry, 2 to 3 times a week, that is fantastic. And we can get them to do that 2 to 3 times a week before they're using a fluoride toothpaste. Well, now we're double whammy. Okay, great. Now, if we're doing that 2 to 3 times a day, we got incipient lesions and we're using a prescription toothpaste. By gosh, I think we'll get somewhere. So there's a lot of different things. Home care, we hammer it at our office. I mean, I think that it's one of the most important things. And I think parents are appreciative of all of that, right? So it's like, it's the type of thing that we try to do on a daily basis.
No, they appreciate it too, because then they have they have guidelines when they go home. They see that, you know, it was done. A lot of times it's done by the nurses before we come in the room, or we re-emphasize it and we force it again. But when they see that it's done like that, and, you know, they go home and, you know, and it might last for a few months or so, but at least we've given them all the modalities and the tools to do it. We see such a difference. I mean, we go down the road, you know, it makes our life so much easier.
Totally. Yeah, if we can get them to do that, that's amazing. Anyways, treatment planning with parents' input, that's kind of the last part about that. All right, we're going to go into cases because I just want it's one thing for us to talk about kind of like what we do and like how we don't do treatment and how we get down the road. These are, I think I have 5 cases here that we've seen in the last like a couple of weeks, and I was like, oh my God, this would be great to like put into the presentation. So first case is and if you guys have questions about any of this, like feel free to ask questions while we're going through them. 4.5-year-old female comes in, multiple carious lesions, second opinion on treatment options, and she was just apprehensive in behavior. I think Dr. Spitz saw this girl, and she first came in 2021. What was recommended was the treatment options, and treatment options were we could take her to GA. At the time that we weren't doing them in our office, we were doing it at the hospital, and it was take her in for GA or do SDF on this child. So, I mean, looking at her teeth, I mean, they don't look good, right? I mean, like GA probably be maybe option 1 here, and that was kind of what we were slated to do, and then mom wanted to do SDF, and we're like, all right, let's give it a shot. Why not? So we go that route.
No, not exactly right. And you're presenting to the parents the options, what we can do, and what might happen, what might not happen, you know, and we're always available. You know, we always can do something more. We are always available 24/7. We share, call, we rotate. So we get called all the time on weekends, and we never abandon our patients. And we probably get maybe 10, 15 a month calls. We're always there, and the parents so appreciate it. Talk about building a practice builder. They thank you 10 times. Just God, I called my physician. He calls me back in 3 days. You called me back in 10 minutes.
It's true.
And I'm sure most of you people do that, but it's such an important thing. So that in the options, again, we're available if something happens. So you're always leaving the door open. It's not like you're abandoning them. They don't want to feel, oh yeah, told me to do this, now I'm on my own. No, they're never on their own.
No, and I think this is like, we'll step through kind of this case because I think when we first started practicing together 14 years ago, we did things way different than we do them now. We would do stainless steel crown. I mean, I haven't used a stainless steel crown in 10 years.
I don't think I have. I know I haven't.
You used to cut them and do all of these crazy things with them and everything else. I'm like, dude,
that was another life.
There's pre-crimped ones.
I don't like the pre-crimped ones.
No, you want to use the tin can. Okay, tin can sounds good. All right.
You can tell we get along, right?
So let's look at time. This is kind of a time lapse, but so June of 21. Recommended SDF or GA. Okay. Did SDF. Now, so our thought process in terms of the way that we think about this, and that's kind of what I want you guys to like drive home with all of this. Once the first permanent molars come into occlusion, those first primary molars, I don't care about at all. I just don't care. I don't mean to be callous. It's like the anterior teeth. When parents come in, I'm like, don't even floss those. I don't care. Floss the back molars, don't floss the front teeth. It doesn't matter to me because at some point the front teeth are going to fall out in the next 3 to 4 years. The first molars, once the first permanent molars are in, and there's discussion about whether or not there is space loss after. James, you could probably talk to me about that a little bit more. But anecdotally, what I see in my office, I don't see a lot of movement. Those first permanent molars are locked in, whether it's class 2, class 3, or straight up class 1. They don't move at all. And I'm gonna stepwise you through this. So those molars there, I think she had a little infection on eye at the time. Patient complains, here's what it was, complaining of pain in the lower right quadrant, took a panner to see everything, put the patient on antibiotics for T. She had a little infection on T, and that was what was bothering her. She had infections on B and I too, but they were not bothering her. So if a patient presents to us with an infection on a tooth and there's no symptoms, we won't put them on antibiotics. We won't do a whole lot with that. We'll tell the parent that we're going to monitor it and go forward from there. But so, and monitor BNI, no extraction needed yet, if they needed extraction. So then this is my like callus thing, but so BILNS and T are asymptomatic, been monitoring, no treatment necessary, exfoliating soon. So now like the first molars you can see, so we're now what, a year, well, this is the last bite wing. So a year from that bite wing, and we have, I mean, eye is about to exfoliate, continued on the prescription tooth. So we put them on a prescription toothpaste early on. The first, I don't know if I said it on the first slide, but we put them on a prescription toothpaste right when they first came in, and then reapplied SDF for all the lesions 6 months prior to this. So like the appointment that was in between the x-rays, because I'm just showing you the x-rays, they came in every 6 months. So the 6 months prior, we put SDF on it again. So now, stepwise out, we're a year out from that, and look where all of those teeth have gone. I mean, they've all exfoliated. I wish that, I mean, she was just in the office, what, like a month ago?
Yeah, we should have
taken
taken
photos, because I think it's really important to see photos of these bicuspids, because everybody thinks that they're going to be hypoplastic and all out of whack, and it's like going to be the craziest thing.
Well,
I mean, anecdotally, I'll tell you, over the 14 years that we've been doing this, there's been like one girl that I can tell you about, and she had abscesses on K and T that the parents didn't want to take them out when she was 3. And those were slightly hypoplastic on the occlusal surface that we ended up taking out for ortho anyways. But we did small occlusal fillings on those teeth and they were totally fine. But the girl would have had to been put to sleep at 3 or 4 and the parents didn't want to do it. We never put her to sleep, and she had these small occlusals on 20 and 29. Anyways, that's another
They didn't
story,
compromise the tooth. They don't compromise the tooth. It's like what you learned in dental school. If you don't do that, the thing's going to come in brown, and you know that does not happen.
It doesn't happen, or at least not in our experience. I can't say it doesn't happen because there's somebody that's going to say it does happen. But it doesn't happen in our experience.
It's very infrequent.
Exactly. A little bit. I mean, you could say that there's a little bit of space loss on the bottom right, which was where T was exfoliated. I'm actually pretty confident that with where 28 is, that it's going to mesialize on that as that 29 is coming up. But so we'll step it forward. So we just saw her a month and a half ago or so. L exfoliated, watching the incipient lesions on the second molar, still using prescription toothpaste. The mom is happy as a lark, this patient, mom. I mean, you were the one that talked to her last time in December, and she's like over the moon. It's like, we should publish all of this stuff because this is amazing what we were able to do. What do we do?
Nothing.
Nothing.
We monitored it, and we did conservative treatment, which she was well aware of, was comfortable with. This is a prime example. You know, had I done this 20 years ago and watched it, I probably would have had my license pulled. No, well, seriously.
I will say that like not a lot of people are doing this, and I'm not saying that everybody should do it. You have to be comfortable with how you're doing it. But look at the permanent teeth though. Like they all are. There's no even watches on those teeth that we're like concerned with. That is another thing. Like that's pretty amazing that like we've gotten to this place. I think some of that is the fluoride, some of that is the home care, some of that is like just stepwise.
A little bit of everything. We're putting it all together as a package.
So anyways, that's one case. Next case, 2.5-year-old male presents for exam, pre-cooperative, no carious lesions, both parents present. So he came to us in like 2015. Then we got our first x-ray when he was 6 years old, but he had LNS were taken out and we put in spacers down on the lower first molars because the first permanent molars were not in. So we do spacers. We do preserve space when we need to preserve space. The reason we put this in is I think it's important to see the lesions on top, but also that the reason that we took out LNS was because they abscessed multiple times. Once teeth start abscessing multiple times and it becomes a lifestyle change for the family, we will then go and do a different direction.
No, I agree. I mean, after you've put them on antibiotics and it's localized, it comes back. Yes, it's time to do something different.
Yeah. And
we have the modality, and with the spacers we can, especially as Dr. Davis just said, you have to do it a little bit different until those 6-year molars come in.
Yeah.
And once they're locked in place, you might lose a tiny bit of space, but we don't have like a Panorex to show you that the child probably will need orthodontic treatment anyhow, and you might have regained space. But you're not losing space, and you're not compromising the child beyond what should be.
So
Parents appreciate that so much. When
Totally.
the conservative approach we take, I mean, we've had many come in that have gone to other places that want to put in. They come in, they want to put in. They come to us, and we tell them. They start crying. I've had that happen many times. There are a lot of ways to skin the cat. This is what we do.
Totally. I completely agree. I mean, you put 10 dentists in a room, what's the joke? There's like 12 treatment plans. Yeah,
That's right.
That's exactly right.
For sure.
So go, Sean.
Do you find that on the large carious lesions near the pulp, if you add SDF, that they abscess sooner?
It's a great question, Sean.
Yeah.
I love this question. And the reason I love this question is because the way that I treatment plan this is going to mind bend you a little bit. So when I see big carious lesions, I will not treatment plan. So when we treatment plan SDF, we treatment plan depending on how many teeth are in the quadrant that we're doing, but we'll do half the number of teeth in the quadrant with SDF. And we just do all of the teeth, right? So I'm stepping into your question in a second, but like on primary teeth, usually the first primary molar is the one that has the bigger carious lesion, and then it's the second primary molar that doesn't, and they're back to back on each other. So I'll treatment plan A, J, K, and T for SDF, and I wish I had something to show you on this so that I actually don't say that I'm doing it on I or doing it on L, because there's a chance that could abscess. Although I will say this, and Dr. Spitz does it more than I do it, but like a kid will come in that is symptomatic on a tooth and he'll be like, oh, let's throw some SDF on it. I'm like, well, I don't know if I'd do that, but like he does it, and more often than not, it works. Yeah. So, but I do know that there's a lot of people that say that there's like pulpitis that comes after the SDF if it's super close to the nerve. So I'm going to do that tooth with SDF, especially on the periphery. But I'm really going to do it on, if that's on I, I'm going to do it on J, and it's going to just kind of,
it'll percolate in a little bit. So it's
just
really hard.
It's hard to happen. Exactly. And just in case it does happen, because if they call me back and they're like, hey, we SDF'd I, I'm going to be like, no, we SDF'd J. Right. We got on I, we might have to take it out just to like kind of play that. Yeah.
But we don't see it that much. So. No. And that's hard to define. Yeah. If it's in fact the SDF or if it's the tooth that's becoming more acute. So you can't really define it.
I will say, and you'll see some of these lesions that don't do anything. So with this little guy, so now this is the first panel that we have, holding space. Oh, sorry. And then just kind of monitoring the lesions on A, B, I, and J, and using a prescription toothpaste. That's like all we're doing. Watching the upper first molars now that they're the large lesions at his age, no treatment necessary. Parents happy with that option. So we're going down the line of kind of watching these teeth exfoliate, and like a year later, you're having these roots resorb, and there's been no discomfort or pain. And don't get me wrong, there's some patients that we do see that come in for an antibiotic in between, and then the tooth goes dormant. And that happens a lot with primary teeth. You give them an antibiotic, they might still have a fistula. They come in 3 weeks later. That's when we kind of, if we give them an antibiotic, we'll see them in 3 weeks. And then we'll just see how that tooth's doing, right? They're on the antibiotic for about a week or so, and then we'll see them 2 weeks after that. And most of the time asymptomatic, and then we'll see them for their regular checkup in 6 months after that. And most of the time asymptomatic. I mean, there's times that we do other things, but these are kind of the cases that have worked out well. And this is kind of what we do on a daily basis. So I exfoliated.
Question.
Spacers were removed because 22 and 27 erupted.
Question.
Go.
Doc.
Oh, go. Sorry.
So you're saying you don't extract the tooth. When it's abscess, you don't necessarily extract it.
So twofold to that. No, I don't just extract it because it has an abscess. I extract it if it's the permanent tooth is now in the wrong plane, and it's coming, like if it's ectopically erupting and coming out super buccal or super lingual, I'll take it out. That happens rarely. Or I'll extract it if it's a lifestyle thing, right? So like parents are like, I'm going on a trip to Egypt next week and I'm going to be there for 2 weeks and I don't want this to inflame. There's some parents that don't want to take it out. We give them antibiotics to take with them on their trip, and don't take the tooth out. But yeah, I extract a lot of teeth, but am I extracting a tooth just based on it being abscessed? No. How old is the kid? What's the symptoms? Like, what's the pain? How annoyed are the parents at the whole situation? I mean, those are all factors that go into it. So yeah, I mean, there's some a kid could present with this same thing, and the parents are like, "No, take them all out, or do fillings on them, or whatever." And we do that. I think that, like, in the last since we moved to the new office like 4 years ago, I feel like we've really stepped it down. Like, we're going in a different direction, and parents and families have appreciated that.
And we're available.
And yeah,
we're always there between the two of us. We're never walking away from patients. So if something happens late in the day or on a day when either one of us are not, we're always available.
Yeah.
Parents know that, and they know that they can call us. So we're never abandoning them, but
yeah,
which leads to us
I agree.
taking a more conservative approach.
Go.
This idea, because we used to hear these stories about a tooth infection becoming systemic and all this stuff. Like, what are the chances of tooth number I having an abscess and then now infection spreading and
Like
becoming
cellulitis
systemic?
and like is now Ludwig's angina. And
Yeah.
Or like,
on the
or
lower
just
end.
going to becoming,
yeah.
I don't know, like a
The
blood
cavernous
infection.
thrombosis, which we were all
The
taught in
likelihood of
dental
that,
school.
in terms of how many abscesses I've seen that I've monitored in the last 14 years, I mean, I can't say it's zero, but it's got to be somewhere close to zero. Has anybody seen that here in the office? Yeah.
What?
Yeah. Impending Ludwig angina, meaning on what, 19 or 30?
Oh, really?
Yeah. That's typically when that happens. Yeah. Yeah.
Our compliance with parents and what we tell them to do is really very good.
Yeah.
You'd be a little more worried.
And I think that is, I totally agree. So let me step back a second and say that my two brothers that practice pediatric dentistry, they have 5 offices in Tucson and they have 2 offices in Maine. Totally different practice styles. And we talk about it all the time in terms of like how we do what we do and how they do what they do. And there's an office in Maine that is a little bit more fee for service, high end. Go ahead.
Well, so in our M&Ms,
But adolescent, so my thing with that, and I'm not saying it doesn't happen, but my thing with that is, when was the last time that adolescent saw a pediatric dentist or a dentist in general? I mean, you probably don't know that, though. Yeah.
Exactly.
So that I agree. So I think that's like, what we do is different, and we can do it, and we feel comfortable doing it because of the touch points that we have with the families that we have.
does that point out though with infections, not too worried sometimes if they get systemic. No question that the C-reactive protein, the ESR rate, a bunch of other markers.
Yeah.
That's a different
Yeah,
story.
totally.
That's totally different.
But that's something
Yeah. We'll bring up with what, like parents in the office. Yeah. No, totally.
I would add a little bit more.
Totally. I think that, I mean, like I said, we're showing you the cases that we've done like this. We do GAs regularly too, right? So it's like having both modalities, I think, is what we do and we do well. And not to say that one day that won't happen where we're using your services at Peninsula, and I'll let you know about it. I hope we don't, but yeah. Anyways, thank you for that. Anybody else have a comment about that? Go.
Microbiome in the mouth
Yeah.
Is it, and we know we get our microbiome from our parents.
Yeah.
Is it also possible that within certain subsegment of population, maybe the microbiome error more towards a more severe infection versus certain populations maybe less virulent? I don't know if that's something you can
It's in all honesty, like with what we see in my office, like it's not just one subsection of a population. It's not like just like the white kid or the Chinese kid or whatever it is. Like it's not any of that. Like it's all the same. And we see, I mean, we have our practice is very diverse in terms of that, but I mean higher socioeconomic status than, and they're showing up every 6 months. If we tell them to show up every 3 months, they're showing up every 3 months. And they do appreciate the level of like kind of service and care that we give in terms of giving them the treatment options to do all of those things. And like to your point on like, do we take teeth out? Yeah, take teeth out on a daily basis. But I think my point to it is that not that it doesn't get to Ludwig's angina, not that it doesn't get to Mills Peninsula Hospital, but that most of the time it doesn't get to that. Like you might have seen one case, you might have seen 180 cases last year or whatever, but like, no, I know that. Yeah. But I like if they're seeing somebody on a regular basis, I don't want to say the likelihood of that is zero, but it's tolerable in my world in terms of that. So, but anyways, looking at this, so I mean, K, T, we're watching. J, we're watching. I mean, and I mean, you just watch these things progress. And there's kids where these teeth don't come up this quickly, but when a kid has an infection, I mean, everybody can agree that permanent tooth slides up faster, and it does. And so, watching it progress, it falls out, it comes out. We don't do anything. He's congenitally missing 31. Great. Goes into ortho, has a Mara appliance, and then like you can see how, I mean, this is just, I guess, the last x-ray he was just in, but his last x-ray was from June of last year. Any questions about any of that?
Oh, I just want to say, you're not the first pediatric dentist I've heard that would leave an abscess tooth alone. Like, there are other pediatric dentists, and the first time I heard it, it surprised me because I saw an abscess tooth number B on a kid.
Yeah.
I sent them back to the pediatric dentist that I work with closely, and then they said, "Oh, we could just leave it alone," and it shocked me. But I understand the guideline.
Yeah, I mean, listen, everybody's got their threshold, right?
Yeah.
And it's, I think, with this, if patients weren't coming to show up, I probably would take out every tooth. I'd be like, all right, like we got to go to GA and do it all at one time.
Yeah.
And it's also different. So I like just anecdotally talk about my brothers, but we talk about this all the time. And he's like, listen, I have families that come into my office that are on dental insurance one day, and then in 6 months they're not on dental insurance. So how do I justify to that parent that I'm going to take the conservative approach when they were here in my office, and then 6 months from now there's an abscess and there's something that we have to do, and now they're not on dental insurance? That blew my mind. I don't have that in my office. Like that, true. What do you do? And so he's like, we have to be super aggressive the first time that they show up, because if we're not, and they get kicked off of their dental insurance because they're in the they're in Arizona, right? The mid range. So they're under 30,000. They get state-run healthcare. If they're over that, but below, like, I mean, poverty level, I mean, it's crazy. They don't get any insurance, and so they're paying out of pocket. So, yeah, I mean, there's different realms to that. So I do agree. This is. I actually have a picture of this one because they just came in. So 6-year-old male came in, second opinion, top left. They saw a dentist that filling fell out of eye multiple times. I mean, he's 6.5. At 6.5, again, I'm not that worried about first molars, but like, or first primary molars. So these are the 2 lesions that from the previous dentist that, or the x-rays that we got from the previous dentist. So when he came in, we took a pano, and you can see eye has abscessed. Then the B, we're kind of monitoring that. you can kind of read what I said before. We placed him on prescription toothpaste, and then I was asymptomatic, and that we would, if it became symptomatic, we would take it out. So like, it's one of those things like where parents are on board. Okay. So, and then tooth broke down to a point where just the root tips are left. And then I point those out because I think this is another thing. If you're taking out a tooth, like general dentist, I don't know in the room if you knew this, but if you're taking out a primary tooth and you fracture a primary root, leave it. Don't go for it, right? So just leave it in there. It'll resorb on its own. It's totally fine. So those roots are left, and lesions that we're kind of monitoring. And then on prescription toothpaste still. So this is the next x-ray. So this is from a year and a half ago or so. And you can see there's no more root tips. 12 is fully in. The other lesions are growing at a not a rapid rate that I would be alarmed with. And this was the last time that he was in. You can see where that bicuspid is coming down. You can see that L has gotten a little bit bigger, but we're just monitoring. Look at where this bicuspid, I mean, you can't see it here, but like, look where this bicuspid is. I bet if you took a pano, you could see that these teeth are going to fall out pretty soon. Anyways, and then I took a picture of the tooth because everybody wants to see the tooth. So look, 12, I mean, you can kind of see it in the mirror there. The mirror was a little watery and scratched, but the tooth, beautiful, beautiful tooth. Had an abscess on it, beautiful tooth. Anyways. Next one, case 4. 2-year-old comes in, nothing doing. We kind of stepwise through with her, has these little incipient lesions. We kind of talk about it. We don't do anything with it. We just say, hey, listen, just floss more, use a fluoride toothpaste. They were. Go a year later, lesion L got a little bit bigger. I did a filling. Holy Toledo. See, I do fillings. Every now and again, a blind squirrel finds a nut. Anyways, did a filling. So the reason 6-year molars aren't in, behavior is pretty good. So, okay, parent wants to do a filling, let's do a filling. And we did SDF on all the other lesions. I think this is kind of cool because the SDF on just watch this as it goes. So obviously SDF didn't work very well. Our protocol with SDF has changed over the years. Like, we used to do it, like people would say, do it 5 times. We always were like, we're going to do it 1 time and kind of see how it goes. And so that was our protocol up until like 3 months ago. Now we do SDF 1 time, and then we have them back at the next time that we do it, we'll do it at their recall, so that we can stepwise it into 1 appointment. And so we'll do it twice. We'll do it twice within a 6-month period. And the rate of decay not progressing has gotten a lot higher in terms of what we've seen. So anyways, did another filling. Can't see it yet. All right, you'll see it on the next slide. And then you can see congenitally missing 4, ectopic eruption of 3. Okay, not really worried about it at this point. So to Dr. James, Dr. Andrews, like in terms of ortho in the house, we tend to do ortho when the 4 anterior teeth come in, 4 permanent anterior teeth come in, 4 lower permanent anterior teeth come in, and the 6-year molars come in. So on this, like, it's obviously like, okay, we're going to have issues, like we're going to have to do something, but let's see where this goes. So I did another filling on I because the 6-year molar wasn't fully in and the parent wanted it done. But this is kind of what I wanted you to look at, is the SDF that was on S. Like, you can kind of see that lesion here, that lesion here. So that was a year later. That lesion has not grown. That lesion is stable. They're using a prescription toothpaste. They're like mediocre at flossing, and it's still stable. Pretty amazing. Go forward. So at this point, she was in crossbite with the posterior molars bilaterally. So we sent her over for an RPE. Had an RPE done. This is the RP. Look at the lesion on S. This is now 2 years after we put 3 years after we put the SDF on. Hasn't grown at all. This is a little bit longer with the RP was removed. Canines are in a better spot. Everything's kind of moving in the right direction. Initially, we were going to treat this as a 4 bis case, and now we're thinking, I'll just show you. So S is now exfoliating. The other teeth are exfoliating. We're probably going to do this as a unilateral 2 bis case. Instead of taking out 2 bis on the left side, we're just going to take out 1 bi on the right side because congenitally missing 4. never done this before. This is my daughter. We're going to do it.
All right.
Yeah.
Is she class 2?
She is not now. She's actually class 1 randomly, like because of the space loss on the bottom. And once teeth pops out, here, I'll show you this. So tooth is coming up. This tooth is mobile now. Once that's out, I'm going to pop out 28 and let 30 drift a little bit as 29's coming up. Question? No? Okay. Sorry. Case 5. This is a cool case. He just came in yesterday, and I was like, I'm going to throw this in. So he came from another office, had a bunch of work done under GA, and it looks pretty good. We take panos. I guess they didn't have a pano at the other office, and then you can see idiopathic resorption under some of these fillings and crowns, which happens like when you do pulpotomies, as we know. And as we move forward, teeth exfoliate, idiopathic resorption, we're kind of just monitoring, nothing symptomatic, everything looks fine. There's recurrent decay that we're just going to kind of monitor, recurrent decay that we're just monitoring. Oh, so, and then he loses S&T, and we're like, okay, like we probably should put in a spacer here. And we're like, okay, mom was like, do we need one? Do we need one? And I'm like, let's see. This, like the occlusion, weirdly enough, held that space, and that it looks like it dips a little bit, but just kind of watch this go forward sequentially. And so this is when we just saw him, and these teeth were all erupting. And so you're looking at x-rays and you're like, that looks good, but is it really that good? I'm telling you what, his mouth was incredible. I had to take pictures of it with my iPhone. I don't have a good camera in the office. I need to get somebody to get me a good camera for my office. Do you have a good camera in your office? Pretty good. I think my camera's all jacked up though. I've dropped it so many times on my phone. But so anyways, it didn't look like, I was like,
They're not as good as
no, yeah, but pretty good. Yeah. So anyways, but like teeth look pretty good. Bottom teeth look pretty good. He's class 1. He's got spacing. I mean, granted, like this case ended pretty darn well. And he has 2 younger brothers that are like the same exact as him, except they didn't all have stainless steel crowns all around.
No, because they were younger, right?
Yeah.
Right.
Yeah. But like, I mean, again, mom happy as lark. Oh, next, AlphaBite. We were talking about 3D printers. AlphaBite, I mean, I'm affiliated with this, so don't take anything that I have with a grain of salt, whatever. I think it's cool, though. I think technology is cool. Scanners are cool. If you don't have a scanner in your office, I think it's important. I mean, I can't imagine taking an impression these days.
It's been a while.
It's been a while. So scanners, AlphaBite is a software that works in like pediatric dentistry, but it started with kinder crowns to zirconia crowns, really hard to do. So they Rolodexed with kinder crowns so that you could scan a tooth and get the exact size of the crown for the tooth, and then prep the tooth, and it would show you how to prep it. Now they print with Xylo 3D, which is a 3D printer out of Egypt that they have 20,000 crown options, and you just print it same day, which is pretty amazing. They're like when I was in the booth in Denver for the AP, our shirt said 25-cent crowns, because literally you can print crowns for 25 cents, which is pretty amazing. And the wear material for it, the material is actually a lot better than you think it is. So anyways, it's something that, like, I mean, you can see the picture that is from my little brother, the printed and then the milled look pretty similar. I mean, pretty amazing in terms of that. This was like one of their like anecdotal things, but like, you know, a patient comes in for an SDO, they haven't been in for a while. So now, like, what are you going to do? A huge composite or like with AlphaBite, you could scan and then print a crown that fits the exact tooth. Like we were just talking about, like permanent crowns. I mean, they're doing this on permanent teeth too, which is kind of wild, like thinking about that. And like something that can be, you can print a crown. So the way that 3D printers work is it's layering, right? So a crown, a pediatric crown, is pretty small in terms of it, prints in 15 minutes. Pretty wild how quick that is. You print night guards, mouth guards, sports guards, things like that, takes about 45 to an hour. So different thickness and everything else. So it's all about height in terms of that. But This is their whole thing: scan, select, source, prep, seat, and it works really, really well. That's my little brother doing that prep, and kind of funny. Xylo 3D is the printer. This is what it looks like. I think it's cool. It looks like an iPhone. One of like the things that I'm like affiliated with, and I mean, Sprint Ray has a great product. It is a big product. This thing is 20 by 20 by 24. It is small. It has all three containers. It has the printer, it has the wash, and it has the curing light all in one. So it can sit on like a laptop desk, and it would be super easy. And we're getting it in the next month into our office. And the cool thing about it is like when kids see something printing, like kids come into our office all the time. I don't know if they come into your office all the time with like 3D printed things. Like you're going to print something 3D for their mouth. I think that's pretty cool. I mean, it's just a cool little segue thing. Anyways, the process, like we said, 15 minutes to 45 minutes. The most 3D printer systems are 15 to 30K. Xylo is like on the lower end of that, but frenectomies. Didn't think I was going to do a lot of them, but now working with orthodontists in the area, if they want I mean, I don't do them. I don't do baby tongue ties and things like. Do you guys do a lot of that? Baby tongue ties and stuff? Yeah. So I don't. I think there is a use for it, but I usually just do like the orthodontists that want like a frenum clipped for some reason, or a lingual tongue tie on like a 10-year-old that can't like lick their back molar. And I'm like, all right, let's do that. But with a laser, do you use a laser? Oh yeah, so great. I'll tell you the reason I went with a water laser instead of the Solea. I hated the arm. The water laser. I bet it is. Yeah. Super easy. Yeah. Anyway, so it just cuts so clean. I mean, this is literally 2 seconds post-op, 2 seconds post-op, and like there's not a lot of heme, which is pretty amazing. So, trauma cases. This is cool. I like trauma case. He just came in like a week ago and fractured his front tooth, and then I don't know how many. Do you guys do a lot of bonding, like fragment repair, like where you drill out the internal and then okay, yeah. So I mean, same thing, right? So had the piece. I should have taken pictures of all these. I'm not a good lecturer, guys. Like I just don't take pictures of everything. I like to talk. Do we like to talk? We like to talk.
We don't talk.
Anyways, so they have the little piece. I love when the parent comes in with the little pieces in like a bag of milk. I'm like, don't need it in a bag of milk. We're not saving, the periodontal ligament fibers. Oh, all good. And then I try it on to see if it's like fits, and it like, oh, okay, it works. All right, well, let's do it. This tooth was asymptomatic. I didn't have time to do it the same day that he came in. Put fluoride varnish on his teeth, let him roll. Came back, I think like 2 or 3 days later, maybe a week later. And then what you do with the fragment piece, if it's big enough and it fits well, you'll what I do is I go in a ditch out internally on that piece of tooth so that you get a little bit more surface area. I actually don't bevel the tooth itself, but I kind of match it back up, and sometimes do pulp caps. If I'm doing a pulp cap, I make the internal a little bit bigger, just if I'm putting down like some sort of material over the top of the nerve, and then paste them together with bonding material. And now I'm using, blank on the name of the flowable that we use, but it's the Match Easy. I don't know if you use the Solventum. They have natural and bright Match Easy.
It just blends right away.
Oh my God. It is the most amazing. It just came out like a month or two ago. It is amazing. I don't get paid by them either, just so you know, but I should be paid by all of these companies. Jonathan, I'm looking for a check. Anyways. No, but it like, so, and then bond it back together. That's just the piece of tooth that we put back on. You can kind of see the line. So beveling is not a bad option, but I mean, it's not, I don't think it's as quick as just doing a buildup, but I think aesthetically you can get a pretty darn good result with that. First molar substitution. We had one with Dr. James, but this is a different one. That we did a couple years back, but I wanted to stepwise this because I don't think people think about this enough either. If kids come in and they have super hypoplastic first molars, Doing fillings and things like that on them, great. But I look at like the longevity of those teeth over the lifetime, and root canals and crowns and everything else, and the amount of cost that's going to be put into those. And we really like doing first molar substitution. So we're going to stepwise to this child that came to us in 2017. First molars, you can't see 19, but we'll step this out. Pretty hypoplastic, obviously 14, super hypoplastic. All of her teeth are super hypoplastic. Like her front anterior, she actually is a beautiful girl. Like we're friends with her dad now, and he's an unbelievable baker. If you guys ever go to Burlingame, there's a place called Bonjour Bakehouse that is unbelievable.
On
And,
Howard Street. Right on Howard. As
yeah,
you
right
get,
on
oh my
Howard, right
God.
by the park. Victoria Park is right there. And the scones, they're French scones that are made with mascarpone. Unbelievable. I'm telling you, it's the softest, most unbelievable scone you'll ever have. And I don't even like scones. These scones are unbelievable.
Francois. Just go to Francois.
Go say hi to Francois.
Tell him.
He's always sitting out on the little tables outside. Anyways, so first molar substitution. So these molars, super hypoplastic, went forward with, so we, at this point, we had been talking to Dad about doing substitution at some point, because we saw him for the first time, I guess, a year ago. Yeah, so for that year, we were talking about, and his question, what was his question? Do you remember what his question was every time that he would come in? He would ask, well, how do you know that the second molars aren't hypoplastic? Fair question.
We don't know.
Do you know? You don't know.
You
never
don't know, but
the
don't have to
likelihood of
know.
the second molar being hypoplastic, pretty low.
Pretty.
Just in terms of anecdotally what we've seen.
We haven't seen any.
It-
I haven't seen any.
Not severe enough to where you'd be like, oh,
Right.
you got to take those out too.
No, never like that.
Never
if
like
anything,
that.
a little white spot.
So she comes in. Then I don't have the pano. Oh, this pano. Okay, great. So you can see, I didn't put arrows on these, but the best time to take out the
When the
first molars are
furcation
when the
starts.
furcation of the second molar is developing. They tend to not dip down. They tend to rise and come in pretty nicely. So this was right when we saw her, we said, taking those teeth out would be good in the next probably year or two, because if you take it out too late,
early.
they won't move at all. If you take it out too early, there's a chance that it dips down. Although we've taken some out pretty darn early, and I wish I had photos of those, but I don't, that have come up just fine. So anyways, they stepwise through that, we took those out. This is what the molars look like coming up. So this is a year after. So took this, she got them out in September. She got them out in I want to say October maybe of this year. So now a year later, you can see how those second molars are coming up, and then stepwising in. Those second molars are in place. Then stepwising in ortho. Now done with ortho, you can see how her front teeth have buildups and they're all chattered, but not a great X-ray. Or I took photos of these on my phone, and I don't think my camera's very good. Anyways, and then the third molars are coming up, and then just kind of monitoring those third molars. And this is the last time, we just saw her a month ago, and the third molars are coming in perfectly, and it's going to be like that. That final result is pretty amazing.
No, I think the hardest thing in doing this is, number one, convincing the orthodontist. I think this one, did we do this one with you, James?
That's right.
I remember we chatted, and then convincing the parents.
Well, a lot of
But
it
so
is
much,
convincing the parents.
yeah, so much of it is timing, like Dr. Davis said.
Yeah.
When that second molar starts to bifurcate, it's the perfect time.
Mm-hmm.
And this is such a good result. You've saved these people from probably losing these teeth when they're 30 or 40.
That's right. I agree. And we did Ryan with you. And
Right.
I mean, and I would have put that in. I just didn't have enough follow-up to see how those are going, but it's perfect. And he's not in any pain or discomfort anymore too, which was it is exactly right. Yeah. So it's stuff like that. I don't know. Think outside the box. Don't let it go to you at Mills Peninsula. Don't let it go to UCSF for Lugwood's angina. But otherwise, think outside the box. Have fun with it. Go ahead, Sarah.
What causes this?
Hypoplasia.
Yeah, because I remember we learned about this in dental school. And you see it when you see it, there's a kind of pattern on first molars and then the lower incisors.
Supposedly.
And
So that's probably a systemic thing that's causing that,
At
whether it
birth.
was like an infection or something of that nature.
environmental.
Usually, well, it's usually
That, and it also can be genetic. So there's a lot of families. Oh yeah. There's a lot of families that we see where the parents all had some sort of
gosh.
hypoplasia on their
Yeah.
teeth. I mean, you're thinking about
the same one. Yeah, we don't need to mention
yeah.
names, but
Yeah,
dad
so-
and both boys.
Oh, yeah, totally. So, I mean, and there's other families that have it less severe, but in actuality, in terms of the tooth forming itself, it's the bud is more acidic than it needs to be. So the pH level is too low when that bud is
A
forming.
lot of times,
Which is why a lot of it is like, is there infection? Like those first molars start developing right around birth, right? And so if they have some severe infection at that point, you can get that striation on those front anteriors and the posterior molars. Although I will say, and you probably confer to this, and maybe you too, Sean, and I know you can, I see a lot more white spot lesions just in terms of in the last like 5 to 10 years, like in terms of what I see.
there's more. It's
anecdotally.
environmental.
And I
There's
think that
something.
is environmental. I don't know what it is, but it's just white spot lesions in terms of just like not a decalcified spot, but is a decalcified white spot on the front tooth. Hard as anything, not going to decay, not going to be a problem. More of an aesthetic concern on the anterior teeth than it is anything else. But I see that more these days.
Must be the smartphone.
It must be the smartphone. It probably is.
Question.
It is. Go. Yeah. It does not. Not the first molar. Yeah. No, good question. Yeah. So taking out a primary canine prematurely, that will shift it, but nothing posterior to that. You're talking about a first permanent molar, right? Yeah. Okay, and even first primary molar won't do that either. Yeah. So either one of those is not going to do anything. Primary canine, before the permanent teeth come in, it will shift that direction.
Last question. It could be incidental. Sometimes I see a primary tooth where it has a couple exposures.
Yes.
Does that ever happen?
It happens a lot. Yeah. That, I mean, has to do with the pulp. In my opinion, I don't know exactly, but it has to do with the pulpotomy that's there and how the tooth it doesn't resorb the root as well, and it goes off in a different direction. But I also see that with infections as well. So it's I mean, kind of twofold on that. Good question though. Go.
About SDF. I mean, you mentioned quite a few times an asymptomatic tooth. If a tooth is symptomatic, like the kid is sensitive and pain, does SDF relieve symptoms as much as a composite filling would?
No.
Okay.
Well, and a composite filling won't reduce those symptoms either unless you're going to do a pulpotomy on that tooth. Yeah. So it just
by the time the kid is symptomatic on a primary tooth, you're kind of too late.
Kind of too late. Well, that's why we go the watch and wait approach in terms of that. I would put them on antibiotics. I'd see him back in 3 weeks, and then I'd monitor that tooth going forward. And a lot of times too, at least what we see is teeth go dormant, like the nerve doesn't act up anymore, and it's kind of just there, it's inert, and the permanent tooth comes up, resorbs the roots. Once the tooth is resorbing the roots, that nerve is gone.
It slows
anyways.
it down so much.
There's not a lot of pain in regards to that. A lot of the pain that they get from that is food impacting. So we see that a lot too. There's a huge lesion. Food impacts down, starts wedging teeth apart. So people come in and they're like, "Oh, we have an infection, we have whatever," and you can tap on all of their teeth and percuss and palpate, and no pain, no discomfort. Take an X-ray, it doesn't look like anything's going. I mean, they have a big cavity, and that is packing food in between the two teeth, wedging them apart. You floss that area, you keep it clean, and you can go forward from that. Yeah, but that doesn't require, in my experience, doesn't require antibiotics. Yeah. Anything else?
Oh yeah.
Oh, Sarah, you again.
Sorry.
Hey, lady in the front row. Okay, go ahead.
How do you guys make money?
We don't. We do it all for free. Next question. No. How do we make money?
Yeah.
Wow. I don't know. Talk to this guy. I don't know. How do we make money?
And you do a lot of watch and wait and see.
I have a kiosk at Hillsdale Shopping Center on weekends.
So my biggest bugaboo, in terms of, you want to get into like how do you make money, my biggest bugaboo with dentistry is, why do you have to do more to make more? Sounds weird, but like in terms of what we do, you can do less and make just as much by being super forthright and having people come to you from all over the place because they want that type of care. And so what we do, we do well with what we do, and people come see us all the
Yeah,
time.
I think it.
So
I think if you focus on providing health care, and you do, and I'm not picking on you, as opposed to some people, it's how much can I make today? No, because that comes through, and that's the perception is there. I mean, we're not wanting for patients. We try to take care of our people as if they're our children and
Yeah.
family. That comes through so quick, and people appreciate that. And I don't, and Dr. David, I'm not going to do something that's really not absolutely necessary. And dentistry has moved so far forward now with all the new medicaments, which Dr. Davis has mentioned, and things that we do. Parents are so appreciative of a conservative approach. And I am living in my car, so that's just to let you know. So if you want to leave, can I take one of those extra pizzas home to my car? I mean, I'd be happy to.
that's hilarious.
If there's any soda, I'll take that too.
But it's true. But like that mentality kind of drives our thing. Like we always say it in our office is that I won't do anything on somebody else's kid that I wouldn't do on my own. And like that's why I put my daughter in the slideshow. It's like I'm not doing something different from somebody that's from a different walk of life or from the same walk of life. We're gonna walk the same road together. So, anyways, hey.
I'll say, can
You
I
did
say
a
one
great
thing?
job.
Yeah, I did a wonderful job. I held this wall up.
You did.
I'll say one thing. We are all blessed to be who we are. And if you go down and have a good journey in what you do and be kind to people, you're going to always end up at the end of the road very happy. I do look at 4 things, and I tell some of my younger colleagues, which is everybody, that if you keep a purpose in life, always have a purpose, stay social, do your physical activity, and eat well, you go a long, long way. Unfortunately, a lot of people that when they get a little bit older, they retire, and people that retire are waiting to die. I mean, I'm not older. I'm experienced and seasoned. You know, old doesn't exist. But if you use those things, wherever you are, enjoy what you do, have fun with it, stay social. I mean, you know, you can go a long way.
I agree.
Thank you, guys. I'll drink it.
Maybe.
Thank you.
Well,